Good morning, everyone, and thank you for joining our webinar today. My name is Sydney Powell, and I'm in the marketing department here at Revele. I will be the organizer of today's webinar, and we're super excited to have you on the line. We have some great information lined up on all things remote care management, post-COVID and beyond. But before we get started, let's just do a few reminders. We will be recording today's webinar, and I will email everyone a copy of the recording and the slides later this afternoon once the webinar is over. We also have some time set aside after the presentation where we can do a live Q&A, so keep your questions ready. So moving on, I'd like to introduce you to your presenter today, and we have a really nice headshot of Paul on the next page of the presentation. So Paul Hoffman is the VP of Sales and Business Development at MD Revolution. Paul manages MD Revolution's Medicare fee-for-service programs and value-based initiatives with nearly 20 years experience as an accomplished healthcare executive, working within outpatient clinics, large health systems, and multi-specialty practices. Experienced in sales and company growth, Paul leads the identification, development, and execution of new business opportunities and partnerships to expand MD Revolution's footprint within the marketplace and drive business results. In his experience, Paul has started 4 separate companies from the ground up, one in the clinical lab space and a successful healthcare consulting company, HealthLink Consulting, and 2 most recent company exits, StayPay MD, acquired by SwervePay, a real-time out-of-pocket cost estimator for clinics and patients before, during, or right after the visit, and Falcon Care, acquired by MD Revolution in 2019, CCM, AWV, and RPM provider for clinics and healthcare systems. So he's super qualified and has some amazing stuff on today's plan. I'm really excited for you to hear what he has to say. And then quickly about Revele, because there might be some people on the webinar that might wonder who we are and what we do, and kind of why we're hosting this webinar with Paul. So on the next slide, you can see a cool logo for us. So Revele is one of the few end-to-end revenue cycle solutions built for eClinicalWorks users who want an integrated, data-driven, and dependable service. Unlike other RCM solutions that leave your in-house staff following up on claims and answering patient phone calls, Revele offers the expertise, scalability, and efficiency healthcare leaders need to build a richer revenue cycle in a rapidly shifting healthcare environment. We take a team approach to our success. Revenue cycle management automation is meant to support our solutions, not replace it. We assign our clients a client success team lead by US performance managers, and these team members come with years of experience dealing with RCM challenges and are here to help serve the day-to-day needs of customers. You can also expect to work with a billing consultant, coding consultant, team leads, and ECW certified trainer, among other team members supporting the RCM process, which also includes certified coders and patient service representatives. As a revenue cycle management service, our goal is really to be a partner with our clients. We know that staying up to date with everything in the healthcare and medical billing field can be challenging, but we care about your success and want to share our knowledge and expertise with you. If you have questions about how we help our clients keep up with the industry changes and increase their cash flow, we'd like the opportunity to connect. So I'm so thankful that Paul could join us today. He's really put together some great content I think you will find very helpful if you're looking for ways to stay informed and updated on the details surrounding remote care management and more. So let's take a quick look at the agenda. We're going to cover telehealth, remote patient monitoring, programs to close the gaps in care, and a lot more. So it's a great agenda, and we're super excited to have you join us today, Paul. But enough from me. What you've actually all been waiting for, I'm passing it over to Paul.
Thank you, Sydney. That was a wonderful introduction. I should have you on all of my calls before we start. I appreciate it. So I just want to jump right in and discuss some of the changes that happened for the public health emergency, and mainly all the discussion today will be involved mainly around CMS and what those changes and guidelines are today. So obviously we were all thrust into a telemedicine and a remote care world maybe sooner than we were ready for. during the COVID health emergency. Well, that public health emergency has been extended through the end of the year. And Medicare has deemed some of those changes permanent and some of those changes temporary. So the ones that are scheduled to expire after the public health emergency ends, I'm just going to do a quick overview of those ones that have been already flagged as expiring. And the public health emergency has been extended to the end of the year. So after this year, in January of 2022, these codes or these services will not be able to be performed via telemedicine. So any certain complexities of patients that are in custodial care, rest home situations, those established patients will not be able to be serviced or be able to do visits via telemedicine. Some of the less, and I'll go on the next slide, but these are for more of the complex patients or longer visits. Home visits for new patients for complex situations and higher level patient visits are set to expire as well. Emergency visits level 1 through 5. Nursing discharge management will have to be in person next year. And then also I'm going to hop down to hospital discharge and critical care services that right now can be performed via telemedicine. Also some of the end-stage renal disease, the monthly monitoring and capitated codes are set to expire, and some of the observation discharge and day management codes as well. Now, what is not going to expire, or at least what does CMS say is not going to expire after this year? The main one is the E&M codes for established and new patients are set to continue and allowed after the PHE, personal health emergency, ends. My opinion is that new patients will probably be required to have an in-person visit next year, but as of right now, CMS has not given that guideline. That is just my opinion. I also believe there will be some type of frequency rules or check-ins needed face-to-face with the patient to continue that established relationship throughout the year. Maybe it'll be once a year, maybe it'll be every 6 months, but I think some frequency rules will be in play after the PHE ends. But as of right now, these are considered permanent changes. And I'm going to hop down to home visits. So one that I think will stay in place is these home visits for established patients for certain complexities or time-based codes are going to stay in place. They're set to stay in place. I think we're going to see more permanent situations inside people's homes or assisted living facilities that are going to allow not only check-ins via a telehealth visit, but also some more virtual devices to take vitals and assist in having a more of a clear picture of the patient when you're doing that visit. So I do think that these will stay in place next year. And then at the very bottom of the slide, transitional care management was actually approved for telehealth to be administered via telehealth even prior to the public health emergency. It just adoption has been very low in this situation. Transitional care management is post-discharge. The reimbursement is better if you can have that follow-up visit within the 5-day window of post-discharge. And Medicare has tried to boost the amount of or increase the amount of these visits by allowing it to be done via telehealth. It just hasn't been adopted yet. So this was covered prior to the PHE and is going to be acquired or allowed after the public health emergency expires. Medicare also gave some guidance for audiovisual check-ins. That is a separate code to the E&M visits, but I think it's important to note that direct supervision, the ability or what CMS deems as the what is the definition of direct supervision has changed. So direct supervision via telehealth is a big change last year and this year. So a mid-level could can use interactive technology to do these visits, to do these check-ins, and now there's no physical presence required by the physician. The physician must be available immediately via an interactive communication channel, via telemedicine channel, and has to be available at all times while these visits are going on. But this opens opportunities for incident to billing without the physician needing to be physically at the same place as the mid-level, and can increase the access to telemedicine by having mid-levels do some of these services, like E&M codes, these virtual check-ins, transitional care management services and visits, can now be done by mid-level without the physician having to be in the same place. Now, they haven't decided whether they're going to make this permanent, but I think this is one that will be permanent as technology evolves and adoption inside the practices evolve as well. So again, the best use cases for this type of scenario would be any E&M visit, TCM visits, or the audio only or virtual check-ins as well, which are separate codes. So the last half of what I wanted to talk about was remote patient monitoring, and there's been a few clarifications and changes from 2020 to 2021. In 2020, CMS did change or added codes for general supervision for remote patient monitoring. And this is when we really got into this space, because we've been in this space for chronic care management since 2015. It was really a pretty easy transition for us to get into the remote patient monitoring space. Now, when COVID hit last year, obviously we were all thrust into a telemedicine world, and there was no choice. But what that did is it opened up patients and providers to at least experience how things could work and how they could be permanent. So the clarification, for these two codes, the 99453 and 454, this is the setup and the monthly connection of the devices. There weren't a lot of changes in this, but during the public health, so the codes state that there has to be 16 days of connectivity during a 30-day period. And this can include programmed alerts. It can include transmission of the vitals each day, and it could be any type of connection during that month. During the public health emergency, they've actually changed this requirement to only 2 days needed for each month for the 99454 code. But after this year, it will revert back to the 16 days of connectivity each month. Now, the biggest change was what Medicare deemed compliant for the 99457 and 458 codes, the 20 minutes of time that's associated with review of these vitals and what that time needed to include. And they originally said in December that it had to be 20 minutes of interactive communication every month. So some type of direct communication back and forth with the patient every month. And it had to be 20 minutes, and that was the requirement. And they did clarify that then in January of this year, that you can include the review, the synchronous, the real-time interactions, and the care management services similar to chronic care management can all be included in that 20 minutes. And that is how it was for 2020 and how it will continue, or it is continuing to be for 2021. So there really ended up being no change on the clarification of 99457 and 458, but it was really confusing in December, and then it was clarified in January. So with all these changes, what do practices do now, and what is going to be the new normal? What is the new normal, and what do we do this year, next year, and beyond? So there was a recent survey by Deloitte of 680 physicians, and 83% of physicians expect some patient-generated data from either wearables, apps, devices. All of this will be integrated into care delivery. But the implementation or adoption of these services inside the practice is relatively low. And though we were thrust into telemedicine and it was a requirement in order to provide care for patients, it really put on hold any type of innovation when it came to remote monitoring and adoption of those services. It just wasn't the time to implement any new service. And so what we're seeing now, and especially in the last 3 months, is this rush to adopt and implement these services. Also, 84% of physicians, those same physicians surveyed, believe that care teams will be sharing their patients' health data in a more streamlined way. We do have CCD files that go back and forth, direct messaging, but it isn't seamless. It's usually not streamlined. Most EHRs do not usually have this functionality, and a lot of those EMRs aren't talking to one another. And also over a third of the physicians believe that their work could be performed by non-physicians, and it could be outside of the clinic. So who is going to do that? Who's going to take over that responsibility? And that's what we're going to talk about is how do we have programs, either remote patient monitoring, chronic care management, any type of value-based initiatives. How does a physician's practice or health system partner with others to get the best interactive with their patients and also the best data back into the EMRs? So even though we were thrust into this telemedicine world, and patients were too, patient care by providers is still one-on-one. That one-on-one patient care is not going to go away. The modality and how it's delivered may be different, but it is not going to change that patient-provider relationship. So what do we do in the background, and how do we have thousands of interactions with patients every month and streamline those into better patient care? So really, we're at MD Revolution, we're on a mission to partner with those practices and those health systems and the leaders who want to bring that innovation into their practice. So you're still going to have that one-on-one care. It's going to be in the office. It's going to be via telemedicine. But those issues that are going on in between those visits, now we're able to connect to devices. We're able to communicate with the EMRs and the practices, where there are several different ways to reach out to patients, whether it's digitally, whether it's through an app, whether it's through a device, and then get two-way communication back and forth, get a really good snapshot of the vitals and the patient, what's going on throughout the month, and hopefully intervening before the patients go to the hospital or have an urgent need. And so it is really a step forward from what was released in 2015 for chronic care management. Now we can add devices, we can add wearables on top of that, and we can have both services going on at once. And it's not going to affect it's only going to enhance an office visit. It's not going to affect frequency rules in any way, shape, or form. And it's not going to change the way that the providers individually practice with their patients and have that one-on-one relationship. So not only are claims being created, and there's a lot of different services going on, but these types of services can also enhance any value-based contracts that you may have, and then also initiatives through the ACO. So a lot of the items that we do are gaps of care closures and helping then report those back to an ACO. So just quick overview of the codes. We talked about it a little bit, but the new the RPM codes for 2020 and 2021 stay the same. The definitions changed just a little bit, but the 99457 now is requiring interactive communication with the patient and caregiver during the month. So there does need to be some type of communication back and forth between the patient and the care team, and then in addition to reviewing those vitals every as they're coming in. So what all does this mean from an engagement clinical platform? So the RPM and the care coordination, whether it's outsourced, whether it's insourced, whether it's you're using a third-party platform or not, all that is really going to be the hub for these interactions. So it's bringing the care team, any support resources from an outside company, and the clinic providers and the staff, and then connecting the patients and caregivers, whether that's through a mobile app, whether that's through a device, or whether that's just calling and connecting with patients over the phone, and plugging in those devices with those interventions, and then having all that data to report back and forth with the EMR, but also to any analytics and reporting platform. There's really two options when we're using connected devices. We can there is the hub option, which is what I'm showing here. So the hub option in the market is having a freestanding device that's connected at all times, one that you can communicate to. These usually come with an emergency response service included in the hub itself. It has a way to call those emergency response services, so very similar to a life alert service, and are connected over a cellular network. And then peripherals that are needed are connected to that hub. And the hub is connected at all times, but the peripherals are only connected when they're administering vitals. The other option, or the service that kind of choices, we have the hub option, then we have non-hub options. These are usually purchased devices that 9 times out of 10 are connected via Wi-Fi. They might have a cellular chip or be connected to a cellular network. The device itself may have an app and just connected via Bluetooth in order to submit vitals. These usually, they're usually less expensive and require some type of purchase or having an inventory to pass out to patients. So there's upfront costs. The hub devices, the self-contained units, a lot of times are, in our situation, are a monthly service fee, but these are ones that you would own and administer, and also, and a lot of times are keeping the inventory and who has what. Now these, if they are a self-contained device, they're only connected when they're submitting vitals. So for some of those requirements that we looked at for the days of connectivity, they're able to send programmed alerts. A lot of these do not have that capability unless the patient is using a smartphone, a tablet, some type of app with it. The hub devices do not require an app. They are connected at all times and are cellular connected. So it's just two different models. Now here at MD Revolution, this is our preferred way of administering remote patient monitoring, but we do work with clients that have purchased these devices and we integrate with those devices. It is just a little bit more difficult to get interactive communication and to hit those 16-day requirements. You're really trusting on the patient to use the device, use it correctly, and be compliant. And as we all know, that is hard to do. So how do we enhance the hub or non-hub option? Well, here at MDR, we also combine that with our patient app. So this isn't a requirement. You don't need this to be in our remote patient monitoring program or our chronic care management program. It just enhances the experience. So via our app, we can connect to a Fitbit, Withings, any wearables, iWatch, any off-the-shelf cuffs or glucometers can be connected and via the app. And also, if they do have one of our hub devices, they can in real time see their measurements and also their history and how they're trending. We also use this for the digital communication and interactive communication with the patient. So secure messaging platform, they message our care coordinators and our nurses directly. And we can also track steps and some activities. They can do a quick log of their weight, or they can connect a device, a scale. All that shows on this dashboard based on the patient's conditions. We can push what we call quick log alerts and engagements and texts with embedded links for the patients just to give us a quick how you doing, how's your blood pressure, how's your activity, stress level, pain. All that can be done through these apps. So how do we ramp these up? These programs only work if they're scalable, and so it's really about using an analytical approach to identify and enroll patients, taking those enrolled patients and making sure that we're developing care plans, patient education, properly enrolling them in the programs, engaging and measuring the vitals, but also progress for the patient, and putting them on a journey each month and building upon that journey. And then every month, then it's really a rinse and repeat. So it's we can plug in really important to plug in gaps of care initiatives, making what your provider, whomever that might be, or who you're partnering with, making it as valuable as possible in the background, not only just to get these codes billable, but also any other initiatives and leveraging those interactions with the patient in order to satisfy any value-based initiatives or contracts you may have, and then getting returns on those on the investment with the providers or with the company that you're partnering with, and then reporting back the claims, any interventions each month. So what does success look like in these programs? This is just a quick kind of snapshot of what we did with the cardiology practice. We've been a client for a long time with chronic care management. It's all about ramping up and ramping up quickly. And doing that, we did that in the past with chronic care management, continue to do that. But now how do we add on devices? How do we add on, in this case, a lot of blood pressure cuffs and get these hubs out to people's homes? And it's really about scaling and making it turnkey. And that we had to do that because of COVID. We couldn't have a pass out our device plan. So what we did was made everything turnkey, from shipment to setup to connectivity to ease of use, and get people using these in this case hub devices and using them hopefully at least 16 days a month. We personally have a lot of good outcome data on CCM. We are now gathering that data for RPM to see how adding a device, adding an actual connected device changes blood pressures, changes outcomes as far as admissions and hospital rates and days in the hospital, readmission rates, going into that as we speak, and not only seeing, okay, patients that weren't in these programs and now they're in these programs, how about patients that were in a chronic care management program and now adding devices? And we see a lot less attrition with RPM than we typically do every month for CCM. And I think a lot of that has to do with having a physical device in the home. Patients see the value of it. They can call us. They can, if they have an emergency, they have that coverage. A lot of patients are paying for Life Alert out of pocket. They don't do that anymore. They don't have to do that anymore. It's covered benefit now, and really feel a connection with their providers. CCM, it's less tangible. There's a lot of action that goes on behind the scenes, care plan development, and really a lot is hinging on that phone call with the patient for CCM. Well, now we can enhance that with digital engagement. We're seeing a lot more Medicare patients more comfortable with using smartphones and texting, and instead of always talking to someone, we're actually seeing better engagements through digital engagement as opposed to phone calls. And adding those devices are giving us, instead of a self-reported measure, or I know a lot of offices, if someone's taking their blood pressure, they bring a log of what they wrote down their blood pressures were every day, and finding that what patients write down might not be exactly what's actually happening. So we're really excited about having that data and having it really soon. That was really it for the presentation portion. Sydney, I'll kind of turn it back over to you. And if we have any questions, I can stay on as long as needed and answer any questions that people may have.
Great. Thank you so much again, Paul. That was a lot of really great information to take in. So if you missed anything, don't worry. Again, I will send you an email later this afternoon with the slide deck and the recording. So now that we've reached the end of the presentation, like Paul said, we'll take some questions. So if you have any, please type them into the chat panel and we will make sure to get to those. As we wait for those questions to roll in, I want to make sure that you know how to get in touch with us if you'd like to learn more about any of the services at MD Revolution or Revele. So following the webinar, you'll get a quick survey, and in that survey, you can let us know how we did or request for one of us to get in touch with you. You can also simply respond to one of my follow-up emails, and I will be quick to get back in touch with you to see who we can redirect you to get the answer to all of those questions that you might have. We can also help you schedule a discovery call with your practice and a representative, and they can help you chat through pricing and options and next steps. If you're interested but aren't quite sure if it's a good fit, I still strongly encourage you to contact us so that we can put together some detailed information based on eligibility and specific goals with MD Rev or Revele. So it looks like we have some questions. So Paul, the first question is, what are typical costs for these programs?
Yeah, so it depends on the model. Typically for if you were to purchase devices, you're looking, usually each device is anywhere from $80 to $100 per device. And then there's usually a monthly connection charge or data charge with those devices. And again, it's whatever route the practice decides to go, but then the practice is responsible for inventory and keeping track of those devices and passing out. Typically what we do is we price them per the CPT codes for Medicare and the services. So you can also go a model like we typically do, where it's per billable event, and that it's kind of a pay-as-you-go model, no upfront cost, a flat rate for the services. And for both chronic care management and for remote patient monitoring, it's all along the lines of those claims. So it's a low financial risk, if no financial risk for the practice. Obviously, more risk, there's maybe more reward. So if you want to go the route of buying the cuffs, they could produce a larger return. But we've worked with a lot of clients that in 2020 bought those devices, and a lot of them are still sitting in the practices. So just make sure that if you go into that, go that route to purchase them, use them in patients that you know will actually use them, because that's the hardest part with those devices, is to get patients to interact and use them on a regular basis.
Yeah, great. Are any other payers other than Medicare paying for remote monitoring and remote programs?
Yeah, so typically with chronic care management, it's really along the Medicare Advantage lines. We don't see a lot of private payers that are reimbursing for the service. There are a few, and it's gotten better in the last couple of years. We're not seeing that with remote patient monitoring, though. We are seeing a lot of private payers, especially the Blues and United Healthcare, specifically paying for remote patient monitoring. And unlike a lot of other services, we're even seeing a lot of more restricted HMO plans paying for these services because of the prevention of future events. So across the board, remote patient, I mean, again, state to state, it might be a little different. And we want to always check that before we start a program. But typically speaking, generalizing, but we are seeing much better coverage for remote patient monitoring.
Great. Okay. So we hear pushback from physicians that they're concerned that their patients will be challenged by setting up the smart hub. What have you found? And is it practical to send someone to the home for the initial setup?
That is practical, but just not as scalable. And so with the smart hubs, at least in our experience, they're cellular connected. We are typically having a connection call with the patient before they get the hub, just to reconfirm everything. And then they get the hub within 5 to 6 days. So there's a lot of literature you can put in the box. It's already integrated to the patient. There's no setup really necessary. I mean, there is, but it's pretty dummy proof. For ours, it's really just turning it on. It has batteries in it, but it can be plugged in at all times, and it connects to an AT&T data network. So it's really opening the box and plugging it in. In our case, we actually get a notification when UPS has delivered it. So we schedule automatically a call the day after delivery and have the patient take a couple vitals and make sure that everything is connected. Our device, and usually with these hubs, if you take your blood pressure, it repeats back the value, lets you know that it's been received, and has a speaker on the hub. Same with all of those peripherals that you saw, not just blood pressure. So scale as well. It'll repeat back the measurement. You'll see the measurement on the device, and the hub will say the measurement out loud. So with all of those, we've seen a lot better adoption and setup with the hub devices over the freestanding devices. So when you can hand someone or ship someone a device, it may look easier, but there's always an uncertainty, or there has been uncertainty with patients feeling like that we got it. There's no confirmation that we got the value. So we've just seen compliance drop with those.
Got it. Yeah. So can these programs be used to close gaps in care?
Yeah, I mentioned that briefly. So these programs, along with chronic care management, there's a lot of data coming back from either the health system, ACO, or maybe a payer, and gaps that are needed to close. So initiatives can be set for each month. They can be task-based initiatives and be assigned to the patients. And so you can then close those gaps based on what needs to be done each month, and change those initiatives every month and to different patients that are in the programs. And again, the first challenge is getting it scalable and getting a lot of patients using these devices and in these programs in order to close gaps. So after you get a good a saturation of patients that are actually on these programs, then it becomes a lot easier for gap closures to take place.
Got it. Great. The last question I'm seeing for right now is, how can these initiatives help with value-based contracts?
Yeah, so similar to the gap closures, we've seen a lot of, just personally, and there's a lot of data out there that chronic care management reduces, traditional care management, chronic care management programs do produce lower readmission rates, lower spend. It is nothing but a positive for the patient, the practice, and also the payers. One would assume, and there's some data out there to this, but now intervening with real vitals and measurements can only enhance that. So a value-based program is all about the spend for the patient. And so with remote patient monitoring, not only is it good for the patients, and we get a lot of good data, and the patients are generally healthier and at least monitored at all times, it reduces the spend. And we've seen it. We've intervened on a lot of cases where the patients have had emergency events, and we're able to intervene immediately. And then we've seen other instances where we've been able to intervene and prevent people from going to the emergency room.
Got it. Great. Well, it looks like that was all the questions that we had right now. So I'm going to go ahead and wrap the webinar. So remember, if you have a quick moment, please be sure to complete that survey after exiting the webinar. We really want to get in touch with you if you have any questions or want to follow up with Paul on the content of today's webinar. So thanks again for taking the time to join us. Thank you, Paul, for the great information, and we look forward to the next time we can chat. Have a great day, everybody.